Hi, it's Dr. Centeno, and thanks so much for joining us today. I'm just a few minutes late. So today we're going to talk about an interesting topic, total nucleated cell counts. That may sound a bit esoteric, but oftentimes when patients come in for a bone marrow concentrate procedure, they will ask for their stem cell count. So for example, it's pretty common with the PICL procedure, we'll have patients ask for their total nucleated cell count or their stem cell count. And I thought it would be important to discuss what that number means and where it's important, where it may be less important, because I think there's a little bit of confusion there. So let's go through that, and going to go through, as usual, a short lecture, maybe 5 minutes or so, that goes through the topic. And then you can ask questions about that topic or really any topic at all. So let me go ahead and start by sharing my screen. Again, for those just joining us, we're talking about total nucleated cell counts, or the cell counts that you would get with a bone marrow procedure, and what those mean and why they might be important. So share screen here. Looks like that worked. And next, I'm going to go ahead and start this here. Okay, so what does a bone marrow concentrate TNCC count mean? And that's the cell count that you're given with a bone marrow concentrate procedure. For example, patient comes in for a PICL procedure, which is where we come in from the front. We inject ligaments that hold the head on. That's a Colorado-specific procedure, but they're often asking for what is their stem cell count. And the number that we're giving them isn't really a stem cell count. So I wanted to make sure that people understood what that number is. So what is bone marrow concentrate first? So if we take bone marrow aspirate, that's where we use a trocar, a thick needle. We can poke that through the bone, usually of the pelvis. Now, most people think of bone like concrete. It's actually more like soft plastic. So a thick needle can be worked through the bone. And then we withdraw what looks like thick blood. That thick blood is called a bone marrow aspirate. Then we go through various centrifugation steps in order to maximize the stem cell content. So what that means is we're taking various fractions out of that bone marrow in the lab and concentrating those. So for example, in our clinic, we can usually concentrate the stem cell fractions about 20 times over baseline, somewhere in that range. Sometimes a little higher, sometimes a little lower, but it's about 20 times over baseline. Now, what's in that bone marrow concentrate? So we've got plasma in there, and the plasma, as we've seen, is a little different than blood plasma. Plasma is, if you centrifuge this stuff, you'll see this sort of golden colored liquid, and that's called plasma. Now, the bone marrow plasma tends to have more anti-inflammatory molecules like A2M than blood plasma does. Then we've got platelets in there. So we actually make our platelet-rich plasma directly from that bone marrow sample, so we don't usually have to do an additional blood stick for that person. So the bone marrow itself, or this bone marrow aspirate, is fairly rich in platelets. And then it's got nucleated cells. So that's really the count that we're quoting, is the total number of cells within that bone marrow concentrate. Now, there's lots of different kinds of nucleated cells in there. We've got mesenchymal stem cells, which is, let me get a pen here. up in here. And we've got hematopoietic stem cells, endothelial progenitor cells, these big old macrophages in there that come in an M1 and M2 type. We've got pericytes, osteochondral reticular cells, Muse cells, and other cells that are in the bone marrow. So these are mostly focused on the cells within the bone marrow, or the nucleated cells within the bone marrow, that we think play a role in regenerative medicine treatments, but also realize that there's other cells in there, like various types of white blood cells. So when we count bone marrow cells in the lab, we report a total nucleated cell count, or TNCC. So that's the total number of cells of all type that are in that bone marrow. So that's the number that people often confuse with a, quote, stem cell count. So for instance, after like a PICL procedure, a patient will ask for that, and we'll say that their TNCC number was 850 million, for example. Now that's 850 million total cells. Only a small part of those cells are in fact mesenchymal or hematopoietic stem cells. So people often confuse that number we give them, in this case 850 million, with the concept that we gave them a stem cell count. But it's not a stem cell count. It's a count of the total nucleated cells, of which a percentage will be stem cells. And we also need to be a little careful, because sometimes that's not a fixed percentage. So as we get older, we tend to see a bit fewer or less active stem cells in the bone marrow. As we get younger, we tend to have more. So the same total 850 million total nucleated cell count may mean different things in a young person versus an old person. So very important to realize that that's not necessarily a fixed number. Now, we've used TNCC for dosing. This is our paper. When did we publish this? Way back in 2015. And we've seen that it's important for success in things like knee osteoarthritis treatments, but tends to be less important for success in fibrous tissue applications, like healing tendons, for example. So for instance, when we looked at total nucleated cell count and whether it was important for healing rotator cuff tendons, we didn't see an association. And that's probably because that number isn't as critical for success. So we can get away with much lower total nucleated cell counts in fibrous tissue applications like ligaments and tendons. Now, obviously, we always want to try to get the maximum number we can for that person. So how can the doctor do that? And this is important stuff to know, because if you get a bone marrow concentrate procedure outside of the Regenix network, we tend to see doctors who will shortcut this and shortchange the patient. So the first thing is, we're drawing from the back of the pelvis area in here, or the PSIS, and that yields 2 times more stem cells than compared to the tibia. So if you see a clinic using the tibia to get this, they're really starting out dramatically shortchanging the patient, because there are far fewer mesenchymal stem cells in the tibia than there is in the axial skeleton, in this case, the pelvis. In addition, so we're drawing from this area, but is how you draw important? And the answer is it's very, very critical. There's what's called a volume paradox here. Now, you would assume that if you just draw more of that thick-looking bone marrow aspirate, looks like thick blood, from a single site, that you'd get a lot more stem cells in there. In fact, it's the opposite. The more small aliquots you draw, 3 to 5 ml, so very small amounts, from a single bone site, the more stem cells you get. And so we'll see a lot of doctors, just for convenience, stick the trocar in there, draw as much as they need because it's quick. That regrettably will dramatically reduce the stem cell count. So what we require our doctors to do is to go to multiple bone sites using that same poke through the bone in order to up the stem cell count by drawing small volumes from multiple sites within the bone. Takes a lot longer, but it doesn't shortchange the patient. So in summary, TNCC is only important in knee osteoarthritis treatments. The doctor should make every effort, obviously, to maximize the number of stem cells in there and the TNCC. And in order to do that, you have to do a bone marrow draw that takes more time and effort than what we normally see out there. And then finally, if you're getting a ligament or tendon treatment, this TNCC number is likely less important. Nor does it represent the number of stem cells in the sample. It's the total nucleated cell count, of which a very small percentage is going to be stem cells. So let me stop there and see if I can take any questions or see if we have any questions. Let me get out of there and see what we got. Thank you, Stacy. Where's the needle video for the spine? Yep, getting there, Ulysses. We'll get there. Tony, how does Centeno after a patient has cervical ligaments injected with bone marrow construct and non-PICL ligaments, can they receive regular PRP or prolotherapy in those same areas at a later date without negatively affecting or diminishing the BMC that was previously injected? If so, how long should one wait? Yeah, it's a very good question. So what we're talking about here is, let's say someone had bone marrow concentrate injected into a ligament and you want to do PRP or prolotherapy at a later date. Now, you would need to wait longer for prolotherapy, because realize that prolotherapy works by killing the local cells it touches. So it's a chemical debridement type surgery or procedure. And then that causes a brief inflammatory response. So you'd need to wait until those cells are mature and have laid down everything they're going to lay down. So 6 months, 3 months minimum, 6 months, somewhere in that time frame, because you don't want to damage those cells that were put in there as they are producing new ligament tissue. Now for PRP, you can probably get in there much quicker, because that's going to further stimulate those cells through a direct stimulation and growth factor. So that could be done within the first month, let's say, once that initial inflammatory response is over. So hope that helps answer that question. Ulysses, how careful do you need to be when treating scoliosis patients from mild to moderate with PRP or stem cells or prolotherapy? You certainly need to be careful, like anytime you're injecting the spine. So what that means is that you want to use X-ray guidance, ultrasound guidance, etc., depending on what's being treated. Now, for treating lumbar spine, there's going to be bigger safety margins than if you're treating, for instance, the high upper cervical spine, as we've discussed before. Submitted advance by Sherry Scott. Should we expect any doctor doing these procedures to be able to give us this number? If they can't, what should we conclude from that? Yeah, Sherry, that's a great question, because yes, if a doctor knows what they're doing here, they're going to understand that this number is important for two reasons, right? If they're in an application where dosing is important, then it tells them, can they treat one knee or two, for example. In addition, it's important feedback for the doctor, because the higher we can keep those numbers in all of our patients, the better. So it goes directly to our technique in how we got the bone marrow out. And yes, if you've got a doctor who can't tell you that number, they are a rank amateur in this area, and just find another doctor who obviously has more experience and understanding about what's going on. Live on. Hi, Dr. Centeno. A friend of mine wondered if lip numbness can in theory be caused by CCI, especially during flexion and extension. Certainly we can see things like irritation of the trigeminal nerve V2 or V3 that might be related to that. And we've seen trigeminal neuralgia in CCI patients, so it's possible. Ulysses, is it impossible to take stem cells from bone marrow? Not quite sure what you mean. So bone marrow would have lots of different types of stem cell populations in there. And during a bone marrow concentrate same-day stem cell procedure, we're taking out those stem cell fractions. Andy, in C001 technique with head turn, the lateral edge is where the needle is targeted. If 2 cc's per projected on a posterior capsule's lateral edge, will it spread to the medial edge of that capsule? That's not where you would target in a C0C1 technique. So in a C0C1 technique, and the prevailing technique there, I invented because I've got the most experience injecting C0C1 on earth at the moment. The head is turned ipsilateral slightly, meaning towards the beam. The beam is usually not rotated at all or rotated very slightly, fluoroscopy beam. And then the target is above the visible joint line in the middle, not the lateral edge. So you don't want to be on the lateral edge. As far as trying to inject the capsule, will it spread if you get the capsule across the capsule? The answer is generally yes. But again, that facet capsule would be injected in situations where it's important to do that. And that depends on the type of instability and the specific type of instability. Realize when that term is used, a facet capsular injection, it's usually used by a doctor who doesn't really have the skill set to do intra-articular injections with high accuracy. So they're sort of claiming they're injecting the capsule, and we're going to keep that in quotes for obvious reasons. Ulysses, impossible. Okay, got that one. Or is it impossible to take stem cells from the leg? I didn't get that one. Does it work? It's not impossible. You can take bone marrow aspirate from the tibia, but you've got two big problems there. One problem is the bone is dramatically thicker, really almost a magnitude thicker, 5 times thicker, 8 times thicker, something like that than the back of the iliac crest. So you usually have to use a drill, which can cause more pain for the patient. But let's say you use a small handheld drill, you get in there, then you've got half the number of stem cells per unit volume as the pelvis does. So there's really no rationale to take bone marrow stem cells from the tibia. Doctors are doing it for their own convenience, not because it's the best source. So as we always say, if a doctor is doing something that's detrimental to you because it's more convenient for him or her, that's a bad doctor. Andy, roughly how wide is the posterior part of the C0C1 joint in terms of centimeters or millimeters? The average patient, approximately 2 centimeters wide, would probably be a good average number between men and women. Obviously, in bigger men, it's bigger. In smaller women, it can be smaller. Obviously, in kids, it can be much smaller. It's been advanced by DB. Is it possible to be allergic to our own cells in a patient with severe allergic issues? Not in the same way it would be possible to be allergic to some foreign material. Now, there are disease states where people can target their own cells, but those disease states are well known. And wouldn't include things like mast cell activation, etc. Andy, are the upper facet capsules stronger, more resistant to stretch injuries compared to the alar ligaments? No, they would tend to be weaker. You have to realize that in research that is done for this kind of stuff, what happens is that the researchers take a denuded cadaver, meaning you get all the muscle, skin, fat off the cadaver. So all you're looking at is the ligaments and the facet capsules, let's say. Then you start cutting something. So you first measure the resistance to turning or resistance to movement. And then you cut something, you measure the resistance again, you cut something, you measure the resistance again, et cetera, et cetera. So no, the alar ligaments and the transverse ligaments would be some of the strongest ligaments in the body, much, much stronger than the facet capsules, meaning that we'll frequently see facet capsules in the neck leak in patients who haven't had any traumatic injuries, meaning that these are not super strong structures in most patients. Ulysses, can lower cervical instability of the neck affect upper joints? I think we would tend to see lower cervical instability impacting things like the big muscles that can go up to the upper cervical spine. So that's why it may feel like one can impact the other. Stefan, you take the cells out of the basin. Do you do it there because that's where the greatest movement is, or is there more blood? Not sure what you mean there. So we send cells to our lab where they're processed in a clean room. But I'm not 100% sure I understand the question there, Stefan. Ty, hey, Dr. Centeno, I'm a 28-year-old male. I was diagnosed with jugular vein compression. I've had many months of fatigue, brain fog, dizziness, lightheadedness, memory loss, and other issues. I recently had a styloidectomy 10 days ago, but I've yet to see much relief, maybe somewhere on the margins. Also, cervical spine disc herniations, C3 through 5. Remember weightlifting injuries 7 years ago. I'm doing an MRV scan to check for stenosis, but I'm feeling a little lost. Any thoughts you could provide? Yeah, so Ty, as you may or may not have heard here before, not quite sure how long you've been watching the channel, but we generally don't recommend styloidectomy for internal jugular vein compression at all as a first-line treatment, especially in situations where there is instability. And there's a couple reasons for that. The first reason is that internal jugular vein compression is common in people walking on the street who have no problems at all. So we always have to be careful when we see internal jugular vein compression and then tie that back to symptoms. Then the second reason would be if you're unstable, cutting the ligaments that come off the styloid, which is what we're really doing in a styloidectomy, that's going to make the anterior neck more unstable and then lead to other problems that have to be dealt with. So, obviously I don't know your specific situation, but those are just general comments based on what you wrote. Regenics has been advanced by DB. Can a particular dietary change or supplement regimen lessen a patient's sensitivity to inflammation issues for a procedure? Not in a bad way, I think a good way. So for instance, I saw a patient this week who had a lot of pain symptoms. And they started taking the supplement and cleaned up their diet and started just basically on a low glycemic diet. And they lost a good amount of weight. And also many of the inflammatory pain symptoms went away even before we did a procedure. So certainly in a good way, but not in a bad way, meaning inflammation will still happen in someone eating a low inflammatory diet when there's acute injury. What the low inflammatory diets tend to do is to reduce that sort of chronic inflammation that causes problems. And Marie, how often does a patient present with multiple CCI symptoms, but imaging, DMX, or other that does not support that diagnosis? If this is the case, do you still consider PICL based on symptoms alone or supported by imaging? Well, Emery realized there's two different sets of problems related to the upper cervical spine. The upper cervical spine in general is what's causing the symptoms. So one possibility is there are injured structures in the upper cervical spine or upper neck, and that's a craniocervical syndrome, but no instability. And then the other is there's instability, and that's why the upper neck structures are complaining and causing symptoms. So there may well be structures in the upper neck that are causing symptoms. Let's say the right 0-1 facet joint, for example. But there's no instability. That joint got injured in a car accident or whatever. So in order to do PICL, in general, we need some evidence of instability. And if there isn't evidence of instability, then we'll treat the upper cervical structures that are involved, upper cervical facets, nerves, etc., and try to get the person better that way. Now, is it possible someone has instability that's occult, meaning that our current technology really can't pin it down? The answer is yes. So we've certainly treated a few patients with PICL where we couldn't see any instability, but the picture sounded so much like instability, and the exam was so much consistent with instability that we went on that alone. And absolutely yes, meaning I don't believe that our imaging techniques are infallible. They're not. Finn, can joint cartilage regenerate? If so, what treatments have been successful in inducing regeneration? To what extent was it successful? I think if you've got small injuries in the joint cartilage in a relatively young person, meaning someone who's under 45, let's say 40 years of age, you can see joint cartilage heal. And things like bone marrow concentrate, autologous culture expanded bone marrow mesenchymal stem cells, we've observed that to happen. Now, if you're talking about a joint that's completely denuded of cartilage, then no, those joints do not gain cartilage as a result of any treatment that's out there currently. Is it possible that we will see something in the future? It's possible, but the problem isn't as simple as it was once thought, because it is possible or more easy to regenerate cartilage in animal models than it is in human patients. James, is it common for a patient to have both CCI and CCS? Well, certainly. So just realize that really what we're talking about causing symptoms is the upper cervical spine. So something in the upper cervical spine is complaining, and we're getting the symptoms. And if there's instability, then that's craniocervical instability. If it's just an injured structure that's complaining, causing the same symptoms, then it's craniocervical syndrome. Finn, can joint cartilage degeneration present as some sort of pseudo ligament laxity, like a deflated tire? It looks loose, but it's not stretched taut anymore. Yeah, so when a joint gets degenerated, many times it gets unstable, and that small amount of instability is what causes bone spurs, right? The body tries to stabilize that joint. And by trying to stabilize that joint, the bone spurs form. So yes, it's very common I wouldn't call it pseudo instability. It's very real ligament laxity and instability. It may not be easily detected by someone who's not looking real hard. So your average orthopedic surgeon is not really good, for example, at finding small amounts of joint instability. It's not their bailiwick. It's not what they do. They're looking for the kind of instability that's going to require surgical management, and that's a binary decision. Either it's big instability that needs to be operated or it doesn't exist. Obviously, reality is a little different. There's lots of types of instability that don't require surgical management, but can be quite destructive for a joint. Marcia, thank you for the informative presentation. Sure. Barbara, can arthritis in lower back with a very compressed disc maybe Next one here, lower back, a very compressed disc with pain be treated. Yes, we treat patients like that all the time. Finn, what's the typical number of rounds of PRP needed to stabilize a C1, C2 facet? Is one and done, rare for posterior PRP. So if we're looking at the types of instability that can be associated with C1, C2, generally posterior treatments won't help. So for those type 2 instabilities, type 2A, type 2B, treating posteriorly at C1, C2 isn't usually going to be the answer. So that's a hard one to answer because it's really the wrong treatment for that kind of instability. Brian, I've had 3 BMAs 3 years apart. The first was good MSC yield. Again, not an MSC. Well, actually, if you're talking about culture expansion, it may be an MSC yield. So let me not jump to conclusions here. The first produced a good MSC yield, but with each of the subsequent 2, MSC count at day 7 of culture declined drastically. The third produced only 20% as MSCs per cc of bone marrow as the first. Chase said my cells grew more than average. Is there any solution? It's possible that you had some cannibalization. So what that means is that the second or third or subsequent BMAs can sometimes recover in that situation if they're done in a different method. So for example, if we're talking about the average initial BMA, we're going to multiple sites and multiple depths. That's perpendicular to the pelvis. But if we want to switch that up and go to different sites, then we can go lengthwise along the pelvis, deeper along the iliac wing. So it's certainly possible that there could be cannibalization. Now, that cannibalization tends to be uncommon in males and more common in older females. But it's possible for whatever reason, it's an issue with your specific cells. So one way to try to do that is to try to address that or prove that it's a cannibalization issue would be go a completely different route in a parallel to the iliac wing rather than perpendicular to the iliac wing bone marrow aspiration type. Tony, can the cervical facet joints be safely injected using Doppler ultrasound guidance by a fluoroscopy machine? I think I remember you saying at C0 must be done by fluoroscopy. Please tell me if I'm correct or thinking the wrong cervical area. So so C0 through C2 have to be done with fluoroscopy plus digital subtraction angiography. That's an important plus because if we take 100 CRM fluoroscopes in interventional pain practices, probably only 1 in 100 has a DSA package on it because that's an expensive upgrade that usually is only found in vascular surgery or interventional vascular surgery practices. So for instance, an interventional cardiologist would have to have that on their fluoro machine, but the average spine interventionalist didn't choose that $20,000 or $30,000 upgrade when they got the C-arm because there was no need for it. The only time you'd use it is when you're injecting structures like this. So that's the first important plus. Then we get into the idea of, can you inject cervical facets using ultrasound? You can, you just can't do a good job of it. And what I mean by that is, in fact, we just had this conversation with my fellow who was following me this week. We've got a fellow in the clinic. He's there for a year learning this stuff, and he was following me. And you can inject the facets via ultrasound. You just end up doing a shitty job of it. So what I mean by that is that you don't know where it's going within the facet joint. So for example, for someone like myself who's been doing this for decades, who's injected more facet joints in the lumbar and cervical spine than I can count, even at my experience level, I'm going to run into a facet joint that I can't document under C-arm fluoroscopy with contrast, which is much more highly accurate than ultrasound, that doesn't flow correctly in the joint, maybe 1 in 10 to 1 in 20 times. Now, if you roll that experience back to when I first started this stuff, within the first 5 or 10 years of doing this, that would go much, much higher, probably 1 in 4 times, 1 in 3 times. Using ultrasound, you're just going to do a poor job. Now, it doesn't mean you may not get in. You certainly may get in, but you're going to increase the risk of not getting in using ultrasound versus C-arm with contrast. Because the difference is with C-arm and contrast, I can see it going in, and I know if I got in or didn't get in. Ultrasound, many times I'll have no idea. I can kind of see it going where it should, but that's about it. And in fact, even more dangerous, I often can't see where it shouldn't go and where I shouldn't be under ultrasound, where that is very, very easy to see with C-arm fluoroscopy. So why would a doctor do these under ultrasound? It's a good question. Again, we're in that world there of it's more convenient for the doctor, but not as good for the patient. And that's a bad doctor. That's simply the answer there, right? You can't compromise what's easier for you and make it detrimental for the patient. Now, it's cheaper to do under ultrasound. A $30,000 ultrasound machine is obviously much cheaper than a $150,000 fluoroscopy machine that then needs a lead-lined room that costs more money, that then needs a $70,000 or $80,000 a year person to run it, which then costs more money. So there's just no rationale that I can see to use ultrasound in the spine at this point. It certainly can be done, but it just can't be done reliably very well. And can you find a traction device such as a Saunders unit to be either helpful or harmful for CCI? Is there a concern of overstretching ligaments with its use? Does your answer change before or after PICL or other treatments? Depending on the type of CCI, most of our CCI patients aren't going to tolerate axial traction very well. Now, we do have some patients that like that. So that's just most of them. So there's some patients will like it. Now, why do they like it? Obviously one of the things it can do is to offload painful neck facet joints. But in general, it's probably not a great idea because I think it has the risk of causing injury if things aren't stable. Now, if someone had great neck stability and all we were trying to do was to offload a compressed nerve or a pissed off nerve, in the average disc bulge irritating a spinal nerve case, that's a different story. Krishana, does neck injury impact the SI joint and cause dysfunction? We certainly see, and I think there's some circumstantial evidence out there that patients with chronic neck issues lose the stabilizing muscles in their low back. And with specific stabilizing muscles, you can see, or the loss of them, you can see SI joint instability. Now, we also see the other way that presents, and that is that someone has some low back issues and some neck issues, and they're sort of independent, but they play off of each other. Spin advance by Harry Winston. How long between bone marrow procedures do you advise would be the same for PRP procedures? No, bone marrow longer. So you've got to wait at least 3 months for a bone marrow. And if you've got, we were just talking about people in that older female category, you should be waiting much longer than that. Or conversely, you can, as I talked about, change up the BMA technique to get around the problem. So if you're a postmenopausal female, either the doctor needs to change up the type of BMA being done, or we need to wait at least 6 to 8 months between those bone marrow aspirates. Now, very different for PRP. As long as you've got blood in the tank and someone didn't empty the tank prematurely, then you don't have to really wait at all. Now, realize if we're taking high volumes of blood from a small person, they may need to wait just based on that whole problem of not having enough blood in the tank. Marcia, you already mentioned that IJV compression observed frequently without symptoms in the population is upper cervical malrotation due to a position observed in asymptomatic population. Probably. I've never seen a study on that, but I would be surprised if it's not. Again, we always have to be careful because, for instance, we know DMX, for example, digital motion X-ray, that C1, C2 overhang and lateral bending. We know that up to 2 millimeters is probably completely normal there. And once we get to 3 and 4, we start to see it less commonly occur in the normal population, so we can sink our teeth into an abnormality. But that's a really important thing with imaging, right? We have to be careful in looking at a normal finding or something that's found in people who don't have any symptoms and attributing symptoms to it. Andy, okay, so if I got this correct, for C01 facet, injects the needle enters the middle third of the joint, the other two being the lateral third and the medial third. Yes, so you'd want to enter the middle third of the joint, but it's not so simple because you're talking about a cup-shaped joint. So the visible joint line you see is the bottom of the cup. So you can't get in there. So you have to set the C-arm up in such a way as you know where the top of the joint is located, and you can target that top of the joint, which is one of the things that makes that procedure so challenging. Anne-Marie, how common are these treatments in teenagers, particularly 14-year-old male? Any concerns when they haven't finished growing yet? Yeah, sure. Yes. We try to stay away from teenagers as much as possible. So I try to avoid any of these procedures in patients that aren't skeletally mature. We've done a few here and there, but those have been the rare exceptions, with the caution to the parents that we don't know the impacts of interventional orthobiologic procedures on kids that aren't skeletally mature yet. Why is the pelvis the best location for stem cell extraction? It's the best location based on the number. Now, why is that the case? Probably because in the way we develop, there's more need for stem cells in that axial skeleton, and our axial skeleton serves as one of the stem cell reserves of the body. And there are less out here in the extremities. Now, it makes sense, right? Because if you transport us back 30 or 40 or 50,000 years ago, all sorts of things can happen to your extremities. You might lose a hand, you might get frostbite and lose a foot, but you're not losing a big part of your stem cell population because there's less stem cells out here. The axial skeleton would be much more protected, and that's where you'd want to store your stem cell reserve, just to protect the person. In addition, we also have the effects of natural radiation. And again, the axial skeleton is going to be much more protected from ambient radiation than your arms or legs would be. So it's a logical place to store most of your stem cells in the axial skeleton versus the extremities. John, I have CCI. I had 2 PRP injections, 3-1 and 327. Facets along C1 through C1, 2, 4 through 6 did heal, but still having problems with daily head pressure, pulse, tinnitus, Brain fog, masseter muscle and muscle ligament right beyond my jaw or tight and sore. Can you inject PRP right beyond the jawbone ligament attached to the SCM muscle? I know this is a carotid sheath, with arteries, veins, and nerves. Yeah, John, so I need to know what kind of CCI you have. There's 8 different subtypes as to try to get an idea of whether or not PRP injections in that area would move the needle at all. And as far as can you inject behind the jaw, you can. Now, behind the jaw here, I think you mean right behind the mandible. Doesn't really attach to the sternocleidomastoid. Maybe you're talking about higher up at the mastoid process in the skull. And you can certainly inject there. You'd want to use ultrasound guidance there because there are things to avoid, like the external jugular vein, for example. And you don't want to go too deep because if you go too deep, you can get into the internal carotid artery, into the internal jugular vein, the phrenic nerve, the vagus nerve. Lots of real estate you don't want to inject into. So all of those injections are possible to do. The question is, what kind of CCI do you have? Determines exactly what needs to be treated. Krishana, how's the prognosis for rotational instability when treated with PICL? Good. That's a type 2B instability, meaning the number 2 and the letter B. And hi, I'm a 59-year-old woman with CCI, facial pain, horrible. Maybe except on neuralgia pain, could be. I'm going to have a consult with you. I have a cervical hemorrhage. Should I proceed with my DMX? My doc gave me an RX prior to seeing you. Yeah, I think that's a good idea because then we'll have more information on which to try to base a diagnosis and to try to get to a type of CCI. So yes, that's generally a good idea if you can do it. Now, a lot of people don't have a DMX near them or they don't have a script for one, in which case we have to do it the other way. But if you can do it where you get a DMX first, that's a good thing. Rhymes, does it require a long needle for C1-2 facet joint injection? What's the best angle to inject the C1-2 facet joint? In most patients, we would use a 25 3.5 gauge or 25 gauge 3.5 inch needle. The best way to approach that would be posterior and perpendicular to the joint, posterior joint surfaces proper. So anyway, that's how it's done, but it's not something you want to do without a lot of training and education. Not something a nurse practitioner or a physician's assistant should ever do. And if you're a physician, you'd want to only attempt something like this with a substantial amount of proctoring after you were already an expert at injecting other parts of the cervical spine. Krishana, what's the best way to diagnose craniocervical syndrome as a DMX? Can you diagnose craniocervical syndrome through rotational CT scan? Rotational CT scan, to my mind, is mostly a waste of radiation. It's about 100 times the radiation of a chest X-ray, and it's very unlikely to diagnose CCI, the kind we're talking about, if it's present. DMX is good. Now, remember, craniocervical syndrome is, by definition, no instability. So that has to be done based on clinical symptoms, physical exam, etc. Craniocervical instability is where you would need a DMX to look for excessive motion to get to that instability part. Nisa, whenever you refer to a young person, what age does that mean? What about specifically in terms of stem cells? Yeah, a young person for our purposes would tend to be someone under 35, let's say. And then you get into sort of middle-aged people, and then we get, and that's going to be 35 to, let's say, 50. And then you get into early elderly, and that's going to be 50s and 60s, and then you get into elderly in the 70s, and then eventually, to my mind, the advanced elderly or the old by the time you're in your 80s. Now, when it comes to stem cells, we're talking about stem cell activity, not necessarily stem cell number. And for our purposes and what we're talking about, there really isn't an age effect as far as treatment is concerned. Rhymes, is C1C2 facet joint instability causing balance problem, clicking problem? I think the question is, can C1C2 instability cause a balance issue? And the answer is yes. And I always mess up your name. I apologize. I'm going to go with on my name. I don't know if I'm right. Can I live with AAI about 4 millimeters of overhang on C1 each side, unstable neck, not severe instability without treatment, only strengthening my neck and back muscles? Listen, I think you should always give anything like that a trial of conservative care, of strengthening your core muscles. You probably want to get with an experienced physical therapist who can help you do that. And then see which category you fall into. If you know you have that much instability, you may want to monitor it every couple of years, get some updated x-ray imaging to make sure the area isn't breaking down. But if you have less symptoms and can function with just strengthening it, that's always a great way to go. Ulysses, can you treat the upper facet joints that are subluxed a lot? Yes. Brian, Hope Biosciences Research Foundation, I don't know who that is, offered to give me free expanded adipose-derived MSCs under the expanded access pathway, but only IV administration. Should I do it in hope of replenishing my depleted bone marrow MSC reserves? Well, number one, that's illegal. So that's an illegal treatment if it's done here in the United States. Maybe this is outside the United States. I don't know. You can't do that under the expanded access pathway. That would require a one-time IND application. And once the FDA figures out that this group is trying to do treatments that way, they're going to shut it down hard. In fact, that just happened a month ago, 6 weeks ago. There was a guy that was trying this very same dodge to try to get around having to do a drug approval for expanded MSCs, and he got shut down by the FDA. So listen, Brian, if it was me, I wouldn't get involved in the middle of something like that, something that's illegal and likely to be shut down. And more importantly, it's not going, we're talking about two different things there, right? So it's like saying there's a Brian Gates and there's a Bill Gates. They're both Gates, so one should be replaceable for the other. But obviously, Brian Gates and Bill Gates are two different people. They're not easily replaced, one person for the other. One's got one skill set, the other one's got the other skill set. One might be tall, the other one might be short. Whatever it is, they're both human beings, but they're very different. So adipose-derived MSCs are extremely different than bone marrow-derived MSCs, so one wouldn't sub in for the other at all. Rhymes, why do you still have a balance problem after a few rounds of posterior PRP injection? Connecting to the above questions, I've read your thesis about the risk of C1C2 facet joint injection. Please tell me the something, STH. So I don't know first question is who did the injection? How was the injection done? And if you had instability of certain types, then as I think I mentioned above, posterior C1C2 injections wouldn't move the needle at all. So lots of more questions there than answers. Andy, have you heard of Dr. Bruce Mitchell in Australia? He injects for high concentration of dextrose into laxus high ligaments with very good results. 50%. Haven't heard of Bruce Mitchell in Australia. That is very high concentration of dextrose. not really needed. I've never seen an issue with 12.5% dextrose. If that doesn't work, then you just go to something like platelet-rich plasma. The big concern with 50% dextrose is that that's highly hypertonic. So if you inadvertently inject that type of solution, for example, into a nerve, you're going to get much, much more nerve damage, for example, than you would with 12.5% dextrose. So again, I can see the idea. If I further concentrate the dextrose, maybe I'll get a more substantial inflammatory response. But there's a downside risk as well if you inadvertently inject into the wrong structure, or God forbid you got that into an artery, it would destroy the artery, for example. So I'd be pretty concerned about that high concentration for those sorts of reasons. Andy, have you seen torn ligaments in the neck heal with PRP confirmed by MRI? It depends on what kind of ligaments we're talking about. Normally, ligaments in the neck don't show up that well on MRI. If we're talking about structures that we can see very, very readily and easily, and we've got good, widely proliferated MRI protocols to see those ligaments, like an ACL ligament in the knee, we've certainly seen those heal with things like bone marrow concentrate, which tends to be more powerful than PRP for that kind of ligament. Darian, what's your opinion of iPSCs? Are they more potent than MSCs? They have potential to be used in regenerative medicine clinically. So just so everyone understands here, we're talking about induced pluripotent stem cells. Are they more potent than mesenchymal stem cells? No one really knows at this point. I've never seen a head-to-head comparison clinically, so I don't think anyone knows that. I think they certainly have to be used in regenerative medicine clinically, but they're going to be more dangerous until proven otherwise, right? Because we're inducing a stem or a regular cell to become a stem cell. So we're creating something that doesn't necessarily naturally exist in the body. And so the risk factor goes up versus using something that does naturally exist in the body. And that doesn't mean they're inherently dangerous. We may be able to prove that certain iPSC cells are quite safe at some point in the future. It's just that all things being equal, they'd be a higher risk treatment until proven otherwise. AT, how much overhang in millimeters on average does one PICL procedure improve? Not so much in millimeters, but we've generally seen in responders, we're getting about a 1/3 improvement each treatment. So for example, someone that starts out with a 7, then going to 1/3 less, and then 1/3 less, that kind of stuff. Amen. Thank you for letting me know. I knew I was butchering it. I didn't quite know how, but I clearly was butchering it, so I apologize. Ulysses, every time I go to the upper cervical chiropractor for adjustment, those bones never stay in place, or ligaments never heal. So the next step is to get regenerative medicine. I don't know your clinical details, but in general, that's probably a true statement, or one that's usually true. AT, my skull has shifted posterior to C1 and I have C0 through 2 instability. I'm doing CBP in situations where the skull shifters are highly likely to be needing PICL in general. I need to know more about the skull shift, how much it's shifting. So that would be a CCI type 1C. In general, those cases need a PICL, but I think you're doing a good first step, which is getting that curve back, which can reduce the forces backwards or forwards for that skull sliding. So I think that's good. Hope Biosciences Research Foundation is actually doing legit clinical trials, including a hip trial and expanded access for serious patients. I don't know who that is, Brian. I'm happy to look it up. Let me look it up. Okay, so let's see here what we got. Okay, well, that's a little scary. So let's see, I just did a Google search and let's share that screen. So we are currently making updates to the site. We'll be back on soon. Sorry for the inconvenience. So Brian, I have to tell you, that doesn't inspire hope in me. Let's see what else we got here. Sugar Land, Texas. What can we learn? Yeah, Brian, I can't learn too much, but it certainly looks like an interesting thing. I will look into them some more. But again, you can't use the expanded access pathway in that way. So I did a whole investigation on this. So if you go to Regenexx, you type in expanded access. There's a whole blog on this. So why don't you read this blog? Can you use the FDA Expanded Access Program to treat orthopedic patients with culture expanded umbilical cord MSCs? You can insert their culture expanded adipose MSCs. And if you just go to Regenexx site, go to search and type in expanded access, this will come up. And it goes through why, there's companies that are trying to play this game. One of them just got shut down about 6 weeks ago. And the problem is here, and that is that this SBEA, single patient expanded access, requires a serious immediate life-threatening disease or condition. And generally musculoskeletal conditions wouldn't qualify. And there's another concern here. The whole program was put together so it wouldn't impact doing an FDA-approved clinical trial. So be careful when people tell you that we're doing a clinical trial. Oftentimes what they mean is that they are, in fact, just doing an IRB-approved trial, not one that's an FDA-approved IND. But I'm happy to look further into that now that I have it up on my screen, and maybe you can just drop me a line and I'll let you know. And you can, maybe I'll blog on it if it's interesting. If not, I'll just let you know what I think. I think you have my email address. So got that. Andy, let me stop. Let me stop my screen. Okay. Andy, for upper cervical set injections, we were trying to calm down the inflamed joints rather than actually fix upper cervical instability because capsules up there are somewhat useless stabilizers. Yeah, the capsules up there are not the main attraction with regard to stabilization. They may be accessory or secondary stabilizers. Inflamed joints is usually an important thing, or really damaged joints, because we're getting too much damage on those joints. So now there are types of instability, specific types, where you might want to go after those facet capsules, but they're not the main rotational stabilizers of C1, C2. That would be ALAR. Andy, just curious, completely off topic, your last name sounds Spanish, am I correct? It is Spanish, yeah. A lot of people think it's Italian, but it was really funny. Recently, as you guys know, spent some time in southern Spain for those sailing trips. And I'd always been told by my ancestors in looking up that our name had something to do with rye bread or rye grain. Maybe my ancestors were rye farmers. And the funniest thing was in Spain, Centeno is actually It is a type of rye. It doesn't really taste like rye. It's really a type of moist, dark bread. So when people couldn't spell my name, I would say Centeno come el pan. So Centeno like the bread. And in Spain, you can't go into a grocery store without seeing Centeno bread. So they all knew instantly what the spelling was when I said that. So I found out a little bit about my background. I'm named after bread, a type of bread. It's quite good bread. Heart Centeno, mind bothering you guys. Hard to inject sequence 2 for set joints because of bone structure. How would you make sure that needle is placed in the right area? It's hard to inject C1C2 primarily because of what happens if you do it wrong. If you do it wrong, you give the person a posterior circulation stroke, and they're probably disabled for life as a result of that mistake. So that's the difficult part, is staying away from the vertebral artery there. So that's why it's a joint that requires X-ray guidance, contrast, and digital subtraction angiography, and requires quite a bit of experience. So, for example, I've got a fellow this past week. He was following me in the clinic. He's the fellow that we have for this year, with a young doctor that comes in once a year and learns interventional orthobiologics. And this guy's pretty good with a needle. He's already been through one fellowship already, an interventional pain management fellowship. He was a neurologist by training, then did interventional pain management. Now he's doing our fellowship. He's not qualified to do 1-2. I didn't let him go near a 1-2. I had him do some cervical facet joints, just get a sense of where he was, and I think he's pretty good. But it's going to be a little bit before I even allow him with proctoring to attempt a 1-2, and certainly probably not a 0-1. So that just gives you an idea of someone who's been training at this for a while, who's quite good with his hands, who's learned an awful lot about fluoroscopically guided spine injections, and why or how difficult 1-2 can be. Nisa, can you explain how total nucleated cell count stem cells are used, where there are lower high numbers when being injected back in joints, etc.? So remember, total nucleated count is not a stem cell count. It's a total number of cells, of which a small portion of those are in fact stem cells. And we use that count for two reasons. One is dosing. When we're doing things like knee arthritis treatments, and the other area where we would use it would be to get feedback on whether or not we did a high quality or a low quality draw on that patient. AT, hey doctor, just wondering if someone is eligible for OPI sales with fixed cost for one treatment, or is it the price of the entire plan? No, it's per treatment. And the reason why is that we've got a 1 in 5, 1 and done rate. So it wouldn't be fair to the less injured people if it were a single price for a series of treatments. So it's just billed per treatment. We do have two sizes, if you will, of procedures. Medium, meaning we do the PICL ligaments, all the posterior stuff we need to do. That includes a certain number of joints, nerves, etc., that are sort of bundled. And then more extensive, where someone's coming in, they're wanting us to inject their back and their knee and their, whatever. So that's how that goes. Ulysses, have you heard of Dr. Anderson? He'd be injuring people neck without TNCC, claims to inject C1, but never been to him, but I heard of him though. No, I don't know Dr. Anderson, but again, as we've talked about, digital subtraction angiography would be the standard of care for injecting C0, C1. So if he's violating the standard of care, and if he has some sort of potential problem, that's an issue. Okay, guys, thanks so much for watching today. I love the questions, great questions. There are no bad questions. We all learn by hearing the answers to questions and asking questions. And again, educated patients ask questions about what's wrong about them and how the doctor plans to treat, etc. So I will be here on Monday, same bat time, same bat channel, and we'll have another topic on Monday. I want to thank you for all of your great questions. I want to wish you guys a very great weekend. And then one last question. Amen. I got this finally. Dr. Centeno, we really need places to get PICL worldwide. In Africa, Middle East, a lot of people suffering and don't find accurate treatment like PICL. Yeah, so that's going to be a while before that happens. Before that happens, in the next 3 or 4 years, we'll probably see some additional doctors that will get hand trained by myself and Dr. Schultz here in the US, and then perhaps some in Europe, that kind of thing. The biggest problem with going out of the US is we tend to see less interventional spine knowledge outside of the US. That's an industry that's highly developed in the US and less developed in other countries. So for example, in China, it's almost non-existent. I know this because we've been looking at various international sites. In Europe, you can find it, but it's less common than in the US. In Australia, it's a bit more developed than in Europe, actually. And in the Middle East and other areas, very, very poorly developed. So it's just finding good candidates to train. Okay, guys, thanks so much. You have a great weekend, and I will see you on Monday.